Hi everyone, today we'll be discussing vitiligo, which is a common dermatological condition that you'll encounter. Vitiligo is a common acquired pigmentary disorder characterized by the progressive loss of functional melanocytes, resulting in well-demarcated, depigmented macules and patches of skin. It affects approximately 1% of the population and can occur in individuals of all racial and ethnic backgrounds. From the image below, you can see this patient who presents with these lesions on their hand, and you can see how well demarcated these areas of depigmentation are. A positive family history is present in up to 30% of affected individuals, suggesting a genetic predisposition. Vitiligo is believed to result from autoimmune-mediated destruction of melanocytes via anti-melanocyte antibodies or AMAs, leading to loss of melanin production within affected areas of skin. And this picture shows how these lesions might appear in a person with darker skin tone. It is characterized by well-defined, depigmented or amelanotic macules and patches, sharply demarcated borders between affected and unaffected skin, predilection for extensive surfaces and periorificial regions, including around the mouth, periocular areas, genital region, and the perianal area. Typically, it has a symmetrical distribution, often occurring in sun-exposed areas and previously hyperpigmented regions such as the face, axilla, and groin. Depigmentation of hair within affected areas or leukotrichia often occurs. Occasional ocular involvement, including chorioretinal pigmentary abnormalities. And finally, the Koebner phenomenon may occur, whereby new lesions develop at sites of skin trauma, friction, or injury. Vitiligo is frequently associated with other autoimmune disorders, such as autoimmune thyroid disease, pernicious anemia, Addison's disease, and type 1 diabetes. Therefore, evaluation of a patient with vitiligo should include screening for these associated conditions when it is clinically indicated. Vitiligo is diagnosed clinically, however, investigations may include Woodlamp's investigation, which uses ultraviolet light to highlight areas of depigmentation. Affected skin typically demonstrates a characteristic bright porcelain white fluorescence. Laboratory investigations directed towards associated autoimmune conditions such as thyroid function tests or vitamin B12 levels can be pursued if clinically indicated. Management aims to stabilize disease activity, stimulate repigmentation, and improve cosmetic appearance, although outcomes vary considerably between individuals. In terms of non-medical management, we recommend photoprotection, including sunscreen use and avoidance of excessive sun exposure, to reduce the risk of sunburn, skin cancer, and minimize the contrast between affected and unaffected skin. Cosmetic camouflage and skin dyes can be used to improve appearance and quality of life. In terms of medical management, for localized disease, topical corticosteroids and topical calcineurin inhibitors such as tacrolimus and pimecrolimus may be used. Phototherapy and photochemotherapy may promote melanocyte regeneration and repigmentation. Narrowband ultraviolet B or NB UVB phototherapy and Sorolin plus ultraviolet A, the UVA therapy, can be used. For widespread treatment-resistant disease, depigmentation of remaining normal skin may be considered using agents such as monobenzyl ether of hydroquinone, also known as monobenzene. Finally, just a quick word on prognosis. The response to treatment is variable and complete repigmentation is not always achieved. Approximately 20% of younger patients may experience spontaneous repigmentation. Repigmentation is often incomplete, patchy, and typically begins around hair follicles, what we term perifollicular repigmentation. Many patients have a chronic or progressive course, although stabilization of disease activity can occur over time.